Good evening, and welcome to the Caring View, the online health and social care platform run by absolute idiots. I apologise if you saw the third part at the beginning of the show. I forgot to get the intro running. Before we get started, don't forget to hit that like button, hit that subscribe if you're watching us on YouTube. If you're watching us on Facebook, LinkedIn, X, or Instagram, please do give us a follow. And if you do subscribe, you will never miss out on any of our upcoming episodes. Go to www.thecaringview.co.uk for all of our free resources, our podcast episodes, chat show episodes, our sponsors, and our suppliers. You can also contact us directly through there and read all of our latest blogs. Everything we do here at the Caring View is completely free to access to absolutely everybody. The only reason we can do this for free is because we have some absolutely fabulous sponsors. So before we get started on tonight's show, let me just run through our sponsors and please do go check them out. So we have Prosperwell, the UK's leading digital marketing agency. All of these websites will be coming across the screen throughout the entire episode as well. We have CBAT, Care Business Associates Training. Please do go check them out for all of your health and social care training needs. We have Attis Care by Attis Insurance Brokers, your comprehensive care coverage and proactive risk management. And again, their website is there. And our two newer sponsors, we have Log My Care, the intuitive care management platform loved by complex providers all around the country. Do go check those out. And last but not least, we have Florence, directly connecting healthcare professionals and organizations with shifts and training. So please do make sure you check out our sponsors. And as I say, they will be running across the screen throughout the rest of this episode. It is just you and I tonight, Mark. Hi, how are you?
It is indeed. Yeah, not too bad, thank you. You?
I'm good, thank you very much. I'm good. I bought some pumpkin placemats because I am there now, I think. I am there for autumn. So my table has now got pumpkin placemats on it, and I think the rest of the decks are going to come down this weekend. Are you there yet for autumn?
Well, I won't lie. I don't really decorate for Halloween. I think I'm always out and about trick-or-treating with the kids, so I just think, oh, what's the point? So we always do a pumpkin carving session and then put a big bowl of sweets at the front door, and then we're out for the evening. And I just say to the kids, right, let's just go for it. Any road, wherever you want to go in the village, we'll do it for as long as you want. So yeah, we're never home, so I never see the point in decorating. But
oh, I love it. 2 months at least in this house, and it's been the coldest summer since 2015, apparently. So that's it. I'm over it. I am over it. Oh, Mark, tonight we are discussing the thinking thing and the responsive domain. Now, to anyone who is watching this and does follow the news, I haven't seen it yet, and that doesn't mean it's not out, but we are awaiting a more in-depth report on the CQC. We had a couple of months ago the abridged version come out, basically branding the CQC is not fit for purpose, which didn't come as a shock to, I don't think, anybody, in all honesty. And it has posed a lot of questions around the single assessment framework. Will this still be the way that their inspection model is going to go? Is it still the way the regulator is going to work? We don't know, is the honest answer. I don't think anybody knows. We aren't going to focus on the ratings for the rest of our episodes on the CQC until we know more, because that is a recommendation within the report to be more clear around the rating system that they're going to use to score providers. However, we are going to commit to continue to break down the quality statements and the single assessment framework to try and give you all as much support and as much guidance as we possibly can preparing for your inspections. I don't think there's anything more I need to say on that, Mark. Have I covered everything?
I think so, yes, indeed. Let's get on with tonight's show, I think.
So, responsive, Mark, give us the lowdown.
Yes, so the intro for responsive on the CQC website, and I'll share this in the chat in a minute so you can follow along as we go about tonight's show, is actually a lot longer than a lot of the other domains. So it says, people and communities are always at the centre of how care is planned and delivered. The health and care needs of people and communities are understood, and they are actively involved in planning care that meets these needs. Care, support and treatment is easily accessible, including physical access. People can access care in ways that meet their physical circumstances and protected equality characteristics. People, those who support them, and staff can easily access information, advice and advocacy. This supports them in managing and understanding their care and treatment. There is partnership working to make sure that care and treatment meets the diverse needs of communities. People are encouraged to give feedback, which is acted on and used to deliver improvements. So a big kind of summary intro there kind of incorporates kind of everything. And we're obviously going to break down those responsive statements further. So the first one to look at is person-centered care. So CQC expects all providers to meet this. So we make sure that people are at the center of their care and treatment choices, and we decide in partnership with them how to respond to any relevant changes in their needs. Whew, it's like a reading test when I read off the CQC website, I tell you.
It is very wordy, everything, isn't it? It's just very wordy.
Do you know what I find? And I think when it's a smaller introduction, it's a lot easier. But actually on the website, there's different fonts and different text sizes, which completely throws me because, and there's loads of different colors as well. And just, yeah, for some reason it just, yeah. But so.
And for a regulator that harks on about us being accessible and to make sure that all of our information is accessible to anyone, there isn't an accessibility function on their website to convert it into more accessible reading. It is what it is. You're stuck with it.
Yeah, you can't change the like the white background to a black background or anything.
Can't change the font, can't change the colors, can't change the sizing.
No, my eyes drift all over the place when I'm on their website. But so, person-centered care, Adam. Any advice for how we can meet this quality statement?
So, I feel like we're banging the same old drum here, Mark. I've made notes, and I'm going to try and pull them up on the screen and talk at the same time, but look like I'm looking at you all. I think we've been banging this drum for a while, and it's around the fact that a lot of this is very straightforward, and we should be doing this anyway. It's all around how we evidence it now and how we sort of showcase it. So under this quality statement, there are a number of things that the CQC have put to say what this means. So people's care plans fully reflect their sort of physical, mental, emotional needs. People use services and those close to them are regularly involved in planning. People understand their conditions, care and treatment. People can receive the most appropriate care and treatment for them as the service makes reasonable adjustments when necessary. And I feel like, hand on heart, most people are probably already doing this. But there are things that we can think of when we're putting this together. So making sure that our care plans, for, say, things like mobility and diabetes, they're customized to include specific dietary needs. You know, I see many care plans will go, this person's got diabetes. Diabetes is a condition that does this. If people have diabetes, it can lead to this and it can lead to that. People with diabetes shouldn't eat this, this, and this. When actually that is a textbook answer to somebody's condition, and it means nothing to the person whom that care plan's for. So, you know, just make those care plans more person-centered to those individuals. What is it the foods that they do and don't like? Is it the fact that they actually really do enjoy eating a banana? And for them to be able to eat a banana, it's offset by X, Y, and Z. Do we apply high-fat creams to it to sort of reduce the sugar intake while they have it? You know, all those sort of things that we need to be thinking of when we're putting that into the plan. Same with things like mobility, making sure that we've got people's exercise routines in there. Is there a certain way that they walk with their walker that we need to be aware of? Is their gait in a way that actually, when they walk, we need to be aware of their gait because of risks of X, Y, and Z? If we are personalizing the care plans, we need to make sure that we're evidencing it. And it's really simple, really, really simple. Just make sure you've got documented assessments covering all aspects as well. So your physical, your mental, emotional, your social needs. Most of us will probably use digital social care record systems, DSCRs now. And it's kind of hard not to document all of that on the DSCRs, but I would add that to your care planning audits, make sure all that information's in there, make sure it triangulates, make sure what's in your care plan actually matches the assessment, and make sure that the assessment's accurate. You know, make sure that if it says this person wears glasses and they wear glasses 24/7, they actually need to wear glasses 24/7, because it might be that they don't do, but we've only ever seen them with glasses on and we've made an assumption. So it's just about making sure that everything's accurate and everything is triangulating with the care plans. Record your MDTs, so your multiple disciplinary meetings and your multiple disciplinary team meetings. Make sure they're recorded and that you've got outcomes of those being recorded as well, because you want to be able to evidence that sort of partnership working. I know that comes under other quality statements, but having discussions around an individual's needs and logging that within their care plans and within their records just goes to show that actually we're making this as person-centered for this individual as much as we can do. I would say hold regular reviews with your residents. I was speaking to a fabulous person the other day, actually, who is going to be joining us at the Care Show on the 9th of October, I believe it is. And we were discussing care planning reviews, and we were discussing how often they need to happen. Mark, do you know how often a care plan review should take place as per NICE and CQC guidance?
I don't. I've got it on my list, though, as one of the tips to make sure that they're regularly reviewed. And it's on one thing that's quite often discussed. So I don't obviously review care plans now. When I was the registered manager, I used to review them monthly, but it was a laborious, massive task. And you had to be careful it didn't become just a tick box exercise, that you were truly reviewing.
So do you know what the NICE and CQC guidance is?
Yeah, go on.
At least annually.
Yeah, which is
at least annually, or if any needs change. So when I was speaking to this person who's going to join us in October, they were saying that the evidence they like to see within care plans is this care plan is going to be reviewed every 3 months as per discussion with this person. So this person has told us that they want to have their care plans reviewed every 3 months. So we're going to review them every 3 months. We're not going to do it monthly for the sake of doing it monthly. There are care needs that probably won't change that often at all. So that's when you're going to get your care plan reviews that always read care plan reviewed, no changes needed. What it does mean, though, is that every single time a care need changes, that care plan gets reviewed. Someone's got a new skin tear, the skin integrity care plan gets reviewed. Someone's had a fall, the falls care plan gets reviewed. And that's what we need to be looking at under responsiveness is, if I was to come into your service as a CQC inspector and I would say, right, I'm going to have a look at falls, and I see someone's had a fall 3 times in a month, and I go and have a look at that care plan and I only see 1 care plan review, why aren't you reviewing that care plan the same amount of times this person's had a fall? Because you need to keep your records up to date. You need to be able to make sure that the care plan reflects and is current to that person's immediate needs. And so I would say document as much as you can do. Document the sort of review minutes and the review meetings that you have with your residents, and get some feedback from them around the care planning process. Make sure that they're happy with how things are. Oh yes, I feel like I'm being involved in my care plan as much as I possibly can be. Brilliant. Make sure you've got that recorded, and obviously make sure things like your consent and stuff are sorted. Use simple language. We've just discussed this with the CQC website. Don't over convolute it. Don't inflate your words for sake of inflating your words. Use simple language. Use visual aids when you're talking through care plan needs for people, especially when you're helping them understand around their care needs and their care conditions. Don't reinvent the wheel. If there's stuff that already exists out there to help communicate this to people, use that as well. But evidence that you're using new approaches to be able to support people into understanding their care needs and how things may change. Potentially, depending on what sort of setting you are, because I'm not talking now as in just elderly residential. You could be sheltered accommodation, you could be learning disability, you could be working age adults under anything. You could be an older people's home where actually the majority of the people have got quite a lot of their capacity and cognition available to them. Potentially hold your own internal cafes. Here is a dementia cafe, here is a Parkinson's cafe. Do you want to know more about your condition? Or get some experts in, get a GP to come down, get people from charities to come down and support people with understanding their conditions, and they can speak to them one-on-one, so they're not just relying on speaking to the people who run the homes or run the services. And again, evidence that all that is really great work to help showcase that you're doing as much as you can do to support people in understanding their health needs. I'm realizing, Mark, I'm waffling, and we don't have long, and there's about 6-7 quality statements for this one, isn't there?
There is indeed.
Yeah.
Not the longest one, but yeah, fairly chunky.
Yeah, so for me, it's all just around evidencing what you do, providing that choice, providing that guidance, and making sure that it is tailored to that individual as much as possible. Thinking home care. Say you've got a resident with a physical disability, and you're providing them their visits. Think about how they're getting to the clinic or to other places. Are you providing that support? Are you providing them the ability to get buses, to get the tram, to get taxis? Are they actually able to do that? If they're not, are you able to get services for them at home? Are you using at-home IV services so that people can get their treatment that way instead of having to spend nights in hospital? Are you making reasonable adjustments yourselves as well? Let's say somebody's got religious needs. Are you making adjustments within your service to meet those person's needs? Are there dietary needs that you need to make adjustments for? I would go as far as saying, are we actually needing to make adjustments, or is our service actually welcoming at the get-go? Are we a multi-faith, multi-whatever service so that anybody from any faith can come in, and you don't need to go, well, we're going to make adjustments for you. You can say, well, actually, no, don't worry about it. We've already thought about that. This is already in place for you. If you still need more, just let us know. But we've already made changes to our service to be inclusive rather than having to wait for someone to come in and just be reactive. It's not always possible, but it's always nice to think about. What about you, Mark? What's the best guidance on this as well?
Yeah, so I think fully agree with everything you've said. And some of this might overlap with what you've already said, but I'll just go through it. I was trying to cross off as well as kind of comment in the comments as well. So I think make sure that family are involved. And if people haven't got family, make sure that an advocate or people are referred for advocacy. There's a huge section there on the CQC website about that. End of life care and making sure that you're planning ahead so that actually if people's needs drastically change, you actually know how they want to be supported at the end of life. Again, no reason why if you're supporting people actually, something that's quite often commonly done with learning disabilities, but I don't think maybe so much with elderly, actually, if they don't know what they want, actually, could you arrange a trip to, a funeral directors? Could you arrange a trip to a cemetery so that people can see? Go listen to hymns, look at flowers so people can really make informed decisions. Feedback. I think we've spoken about feedback on each of the domains, how you're capturing it and what you're doing with that data. Partnership working, again, something we've discussed many times, but how you're working in partnership with other organisations, whether that's healthcare or whether that's completely other sectors. There's a big bit on the CQC website around people knowing how to access their data that you're sharing with other organisations. So it might be with dentists, with GPs, with colleges. And then Tony, something you were talking about, Adam, with care planning and reviews. They're a reablement service, so they review weekly. So again, making sure that you're responsive to the service type that you are. Actually, one size doesn't necessarily fit all. And I think
I suppose that's around goal making though as well, isn't it, Mark? For a reablement team, you've got loads of short-term goals because and you're reablement, Mark, so you'll be able to back this up. You've got these short-term goals that you want to be able to meet. So they are going to get reviewed more often. If you don't have your loads of short-term goals, and actually you've got long-term goals which you want to review every 3 months.
No, absolutely. And I think with my reablement hat on, actually, are you responsive? So when you do that assessment, quite often people are coming home from hospital. I know my service is home first, so quite often we don't even have any kind of information sent. We're kind of going in blind, but how quick are you getting equipment in there? Talking about like hoist, rotunda, those larger pieces of equipment, but also everyday equipment that all of us, regardless of what service we've got, like long handle sponges to allow people to be as independent as possible. Responsive to soft support with family. So something we quite often speak about with our customers in reablement. Actually, what can family do to support you to live at home for longer around shopping? Can they take you to GP appointments? You already spoke about access in the home. So actually, if people are religious, can you bring that religion into their home if they can't access the community anymore? A lot in the Skills for Care workforce plan, but nothing really yet with the CQC, but it will come because it's one of the commitments that they've made around therapy input. So obviously reablement, Tony will be fine because they're therapy led, but for care homes, learning disability services, not many therapists employed within those services. So actually, how are we going to make sure people are responsive to that? In terms of...
I'm just certain that's everyone's way of trying to take the blame away from the NHS for not having enough occupational therapists and physios to go around, because I speak collectively for all of residential and nursing care to go. Can't remember the last time I saw a physio more than once for one person. It's ridiculous how short they are. Sorry, Mark.
No, it's fine. And again, if you're a reablement service or what, and you're looking at therapists, actually quite often local authorities will say that you need physios. Actually, it might not be. It might be an occupational therapist is actually what you need. So actually, make sure you're pushing back and documenting that. Tony's come back and said part of this review is a written document that the service user and relatives are part of. And again, making sure that actually you're involving everybody, like Tony said, relatives, next of kin, next door neighbour, whoever that person that you're supporting wants involved in their care. So best practice guidance is a dementia assessment that links to the NICE guidance, care and support of people growing older with learning disabilities, again, on the NICE website. Skills for Care's person-centred approaches in health and care, personalised care by Skills for Care, and Caring with Confidence, which is the Nursing and Midwifery Council. So a few links there. Not as much best practice guidance as I would have thought there would be, but...
Yeah, it's very odd. I mean, the only thing that I would add is around people's lifestyle plans, around their care plans that are around social activities, around their hobbies, their interests. It's around making sure that it's not just such and such likes music. Well, actually, what music is it? What time of day do they like listening to that music? Are there specific songs that they like? Such and such likes knitting. Well, do they? What do they like to knit? What sort of wool do they use? What day of the week do they normally knit? What are their best things to knit? And if you're putting in someone's care plan, Susan likes knitting every Sunday in the conservatory, then by God, make sure that happens. Because if I read that in a care plan, the number one thing I'm going to do as soon as I've read that is go into the care notes to see whether it's happened. Because if you're care planning something and it's not happening, you're not responsive or effective. And you're probably not caring either, because it's not happening. So making sure that if something has been care planned, that we're actually following up and making sure that those persons' needs are being met in that way as we've care planned it as well. You pulled something up on the screen. Sorry, Mark.
No, that's okay. I was just sharing around reasonable adaptations in the environment to account for any disabilities.
Yep.
Right. I'm going to move us on to the next one because I'm conscious of time, which is care provision, integration, and continuity. So we understand the diverse health and care needs of people and our local communities. So joined care. So care is joined up, flexible, and supports choice in continuity. So continuity of care, especially for home care, is crucial. I think more so from reading reports, even for care homes and the choices there. So I read one report, must have been last week or the week before, that was talking about how the residents didn't get a choice of who was doing their personal care. It was decided by a shift leader, and CQC in the report have said that actually it should be the person that's choosing every day. How practical that would be, because if they all chose the same member of staff, actually, what are you going to do? But yeah, they are looking at that choice and control element for people. Adam, over to you on this one.
I want people who don't work in social care to stop telling us how to do things in social care, because I swear by Jesus, some of the stuff they expect us to be able to do and actually still provide care is ridiculous. Like, it's absolutely ridiculous, because if you think about it, that would require potentially a mental capacity assessment. It would require to be able to go back and ask them and make sure that they've made that right decision, that you've documented it, and all of that is going to take a lot of time. And with the severe underfunding that we've got in social care, sometimes not everything is 100% possible. Yes, I think we should be documenting whether someone prefers a female carer or a male carer, what those persons' likes and interests are. And I think we can do personality matches within the team to say, well, actually, you match really well with this person and you match really well with that person. So we're going to try it like that and do a bit of trial and error. But you don't in a hospital. Imagine going to a hospital and saying, actually, I don't want that carer looking after me. I want that carer down the corridor looking after me. It's not possible. It's 100% not possible. What we can do, though, is make changes to the way we work to make it more person-centered. This person is going to be supported by people who have similar interests. Her interests are rock music, are quesadillas, and Roald Dahl, for example, and making sure that people have similar talk. It's like putting me to care for somebody and support somebody who all they talk about is football, because not got a clue.
You'd
Like, I
love
literally not got a clue. It'd be my worst nightmare. I haven't got a clue. It'd be my worst nightmare, because I feel like I'm not being able to support that person in the way that they're going to need to be supported, because that conversation is a huge part of dignity and respect and keeping it. So I totally don't think what you started off with this, Mark, is the way forward. And I think people need to get their heads checked, potentially, if that's what they do want to impose. But I do think as services, we can do more to be more person-centered. What was your question?
No, just anything you've got, any tips or tricks to meet which one are we on? Care provision, integration, and continuity.
I would say connect with your local communities. I think that is hugely important. I think we need to be able to make sure that we're aware of what our local communities provide. I think people in our services need to know what our local communities provide, as well as, thank you, April. As well as faith groups, cultural associations. Have we got I don't know. Have we got LGBT communities that actually we can bring them into the home? Have we got loneliness communities which we can bring into the home? And if they don't exist in the community, can we create one? Can we create a community to get other people involved as well? Bring the community into the home. I would say, I don't know. I mean, I'm looking at what the CQC here is saying. So what this means, there is continuity in people's care and treatment because services are flexible and joined up. A lot of this really does rely on other services as well. So I think for me, it's around evidencing that you're doing as much as you can do to communicate to other services. It could be that you're a multi-type service. So you could be home care, you could be residential care. For example, I used to be Meals on Wheels, home care, and residential care. So all of our services communicated to each other. So our Meals on Wheels service would know what people's dietary needs are. They would come on for home care. We'd still continue to provide them the meals. We'd have our home care there. Our meal delivery drivers would then communicate back to the team and say, look, just been to deliver their meal. This is what you need to be aware of coming on your next visit. They would come into respite in our home and we would share the care plan. So internally, it's a lot easier. It's harder when people are using services from different organizations, and it's around making sure that communication is as joined up as you possibly can, and making sure that information is clear, making sure that there's no risk of miscommunication, and making sure potentially actually you get signed receipt. So I have handed you this information. Can you please confirm you've received this information that's communicated? Covering yourself that way, because then if another person makes a mistake, they've already agreed to say that actually the communication is fine. Hospital packs, have you got them ready? Have you got packs ready for people when they go on respite? All of that sort of stuff that we can use to support people. I would say, again, making sure that you've got your MDT approaches when you're doing your assessments of people's needs. Internally, again, a lot easier. If you're a nursing home, can you get the manager, a nurse, and a carer or a senior carer involved? Can you get the kitchen team involved? Can you get the activity team involved? So that actually, when you're doing that full internal care review, you've got all of the different angles of somebody's care needs. And again, making sure we've got relatives and people involved. And then can we outsource and get more people involved? So do we need to have the SALT team involved? Do we need to have physios involved? Do we need to have RIT team involved? All of those different areas that we might need to have included in people's care, just to get that evidenced for being that we're delivering care in a way that meets their needs. Yeah, if it's not written, it didn't happen. Oh my God, the amount of times. So just for everyone watching this, if you're finding that your team are doing stuff and not actually recording it, do what I do, and I put them in the coroner's hot seat, and I role play with them as if we're in coroner's court. And it's the scariest thing ever, because if you've been to coroners, and you don't need to tell me in the comments if you've been to coroners, but if you've been to coroners, you know. If you've not been to coroners, you don't know. It is the worst experience you will ever experience in your life. Well, it's subjective, but it's up there. It's horrible. And sometimes the team don't get that. They don't understand the severity of not recording stuff. If something happens overnight and that information is not in a care plan, you're pretty much stuffed. Making sure that we record everything from care notes all the way up to our assessments, our reviews, our funding reviews. Every single time we've contacted the GP and said, can we please have a medication review? We've documented it in that person's care notes. Because if someone comes around and says, well, their meds haven't been reviewed for like 8 months, 9 months, and they're on 15 different tablets and 6 PRNs, why have they not been reviewed? We can say, go and ask the GP, because we've asked and we've asked and we've asked and we've asked and we've asked, we've escalated here, we've followed up here, we've sent through this. You've got that evidence then to show that actually you're doing what you can to make sure people's continuity of care is happening. Other services are now letting you down. And you know, documenting that you're really trying to connect with that GP surgery and to do more. But yeah, always document, always document. Well, document in a person-centered way. Don't document in a way where it's like tablets given or meds given or wash given. That's the worst stuff in the world. Document it in a way which is really person-centered. Sorry, Mark.
No, you're okay. Just on the subject of documentation, I think if you have got therapists, make sure they're delivering their notes how they would have been trained. So using the SOAP method, I'll share a link in a minute in the chat for that. I think the only things here is around evidence in how you meet people's needs. So are you making sure that you meet cultural language needs? Do you have a list of all the staff that can speak a second, third, fourth language? So that actually if you get a resident, a service user, a customer, whatever you want to call them in your service, actually how do you are you responsive to meeting those needs? Evidence in how joined up care works. Interestingly, on the CQC website, on the best practice, and I'll share a link, they link it to the local authority assessment framework under theme 2. So theme 2 on the local authority framework is around providing support. So it talks about integration, partnership working, commissioning, market shaping. So make sure that, you know, actually you're working with your local ICS, your ICB. Are you on those? If not, try and get on them. Evidence how you're trying to get on them. So actually, if you're sending emails, if you're making phone calls, actually you can say to the CQC that you want to be part of that, but it's not through lack of trying. Other services, it might be the funding. So again, make sure that you're linking people in, especially unpaid carers, signposting them, supporting with what they could be eligible for, upskilling them. The best practice guidance and most of this quality statement is actually very LD heavy, I feel. So not actually much for older people services, but if you're a learning disability service, supported living, then probably actually a lot of information for you here. Right. Ready for the next one, Adam?
Why not, eh?
Providing information. So nice and small, this one. So we provide appropriate, accurate, and up-to-date information in formats that we tailor to individual needs. Now, interestingly, I've never had a CQC inspector really look into this, but when we had our PAMS inspection, they were all over this around how we would give information in accessible, in different languages. What was the turnaround time? Actually, if we ordered today, how quick would it be out? Do we have a supply of them in the office? Obviously, we're reablement. So obviously, our churn of customers is great. We're supporting over 100 people a day in one of our services. But yeah, they were all over, you know, that side of things. So I think definitely make sure that you've got it. Do you have staff that are trained in Makaton, in BSL that can meet people's needs? Transparent information, cleared information, large text font, Braille. Again, a bit like what you said earlier, though, a lot of it actually, from a cost perspective, especially if you're a small service, actually to have a whole stock of them, if you then change your branding, you change your logo, you change your website, whatever it is, actually you've got to consider that you need to then actually make sure that you're changing all of that can have a cost impact to you. Elsa has put easy reversion to service users. Absolutely. Adam, anything on here for you?
I mean, you say it's small, but actually, when you have a look at what this means, there's like 400 things that CQC want you to have a look at. I would start by saying, again, don't reinvent the wheel. Have a look what's already out there. Get into your managers groups, get into your peer support groups, and ask people what they've currently got to support you. Ask people what they've got that might help you in communicating some of this information. I would definitely say lean heavily into audio recordings and video recordings. They don't take that long to do. It's actually quicker than typing. And sometimes that's a really good way to get the information across to people. Depending on your residents' needs, your service users' needs, your customers' needs, whatever you refer to them as, audio recordings might not be good. Video recordings might not be good. Have you got team members who are bilingual in your service that actually can do the recordings themselves in their mother tongue? You know, if they've got the same language as some of your residents, can you utilize your team and go, look, you've got this strength that I don't have, can I please have your support in recording this for the resident, because they need to be able to understand it. And I think they'll understand it coming from you because you'll have the cultural inflections, you'll be able to word it in a way that they will understand. So really have a look at how that information is being given to them. Are we keeping patient leaflets from medications and making sure they're on hand to be able to give to people as well? Or are we actually making little sort of short documents up for people so that they understand what their medications are for? Is your website cough cough CQC cough cough accessible? Is there an ability on there to change the font, to change the color, to change the size of your writing? Are the pictures on your website, do they have descriptions to them? Sometimes when you hover over an image on a picture on a website, it'll say picture of a man. Sometimes it'll just say image 001. Make sure if you're putting images on your website that you're actually putting really good in-depth descriptions into them, especially if it's around your home and your bedrooms, because imagine being visually impaired and going onto a website and relying on the information that's on there to understand that service. And it'll say this website contains a picture, description of the picture 001. And they'll go, oh. However, it could say this is a picture of a bedroom in this nursing home. There is an ensuite room. There is a bed. There is walls that are decorated with X, Y, and Z. And it gives them that sort of information. They can sort of build up that idea of what it is that they're looking for. So making sure that sort of stuff is utilized. And social media, if you're going to put pictures on social media and your picture has a load of text on, so let's say it's a poster, please make sure that that information also goes in the body of the text, because you cannot do a right click and read on an image on social media because there's no information there for it to read. It's a JPEG. It's a flat file. Make sure that the image, the text in that image, is in the body of the Facebook post as well. Otherwise, you're going to make your information not accessible to so many people. If you are using resident portals in your DSCRs, make sure they're secure. Make sure you've got consent from the person. Make sure you've got an understanding from the family of how to use it, and not to share the passwords out. Obviously, everything like that. You want to make sure that you're digitally secure. It's just a lot of it, Mark, is just the same of the same. I don't think there's much more to really say about this, apart from I would just urge you all, if you're panicking around the AIS, the Accessible Information Standard, and getting this information for people, have a look at what's already out there. Have a look at what's available to you and what you can utilize yourself. Have you got your residents' meetings set up? Have you got a residents' association within your home where the residents can get together and discuss it themselves? Do you have topical events on for them to be able to give them further information? Do you show them when you're care planning what you're care planning and what information is going into the care plan? Are you telling them how that information is being used and how your team are using it to sort of meet their needs? Yeah, that's probably complaints. Oh, sorry. Yeah. Compliments and complaints. Make sure they've got the policy. Make sure they've got the procedure. Make sure it's an easy to understand and easy to follow procedure. Even give them a full policy, but also a cheat sheet, a flow chart of, if you've got a problem, this, and this, we will respond by doing this, and this. Or how would you like us to respond? What is the way that you would like us to respond to? But make sure that they understand how long it's going to take you to respond and what the sort of process actually is.
The only thing is, off the back of what you've said, social media. I was asked by a relative association the other day for some advice. And what I would say off the back of this case is make sure what your consent form says and that you're following it. So a relative had signed a consent form for use of an image to be used internally. The company had put them on Facebook. What they didn't realise is that image was then shareable. All the staff then started sharing the image. a lot of those staff then didn't have privacy on their own account, so then was in the public domain. Then when you search this lady's name, which obviously you shouldn't also be doing, you can then find it on Google, it then popped up on other platforms. So do make sure that you're double checking, and you should be listing and having a tick box of where people want their information shared, whether it is truly going to be internal, whether it's for marketing, how long you're going to hold that image for, how people can withdraw consent. I know Adam and I have spoken a million times around social media and images of people, but really, actually, do people really understand where that image is going to end and what's going to happen with it? And I think now with deepfake, with AI, if you're supporting young people and they might be on social media, which is absolutely fine, do they actually realize when they're signing up to some of those AI things, actually that company then owns that image, owns their face? I think if you type it into China or Japan, loads of them ended up on billboards on porn covers, but the AI are saying that they own those images, so they won't take them down. You don't know where your image is going to end up, so you need to be really mindful, actually, whether people truly have capacity around that aspect.
And with that consent angle as well, consent is given, but we should always be checking it. So, you know, and I use this example all the time. I don't mind my photo going on social media. I mean, Mark and I are sort of past the point now of trying to keep our face off social media. So I don't mind a photo of me going up on social media. However, I want to see it before it does. I don't want you to just take that word of me going, yes, of course I don't mind going on social media, is put any photo you want of me on social media, because by God, the wrong angle and the wrong light, I look like Jabba the Hutt from Star Wars. You know, the right angle and the right light, I look a lot less like Jabba the Hutt from Star Wars. And I want to be able to see what that image is. And it's making sure that if our residents have consented for photo use, that photo use consent, like Mark says, details how that photo is going to be used. And actually, that photo consent does not include social media. You need a separate social media consent form. Don't bundle it up with photo consent, because if you're talking to somebody with a cognitive impairment and you're doing a mental capacity assessment and go, do you consent to have your photo taken, which we will then use for your care records, your MAR records, for posters internally in our own little art books, but it's also going to go on social media. Social media is this. These are the different types of social media. These are the different types of social media that we use. This is what the social media means. This is where the images go on. They're not going to retain all that information. So your social media consent form needs to be completely different. And within that consent sort of process, if you're going to put a photo up of a resident, document that you've asked them that they're happy with that photo going up, because otherwise you're just putting an image up of someone without asking them. Yeah, they've consented to say they're going to go on social media, but they've not consented to that photograph. They've just consented to say yes, they'll partake in it. So they've, you know, part one's done. You can take photos of your events. Great. Once you've taken those photos, go and ask them if they're happy with them. You know, how many times have you been tagged in a photo on Facebook after a night out and you've got half a kebab hanging out your chin? You know, it's awful. You don't want that to happen. So it's all around that dignity side of things as well. But Mark and I have done. Mark, I feel like there is an episode coming up where we are going to discuss social media and social care. But for the time being, that's my two penneth.
No, absolutely. And we do need to have it. I have shared a link to an accessible information show that we did. It's one of our old ones, so it's from 2022, so it's a couple of years old, but we were joined by Tracy McGee. But it'll give you a good head start on kind of where to start, what to do, how to kind of review and analyze what you're currently doing in your service. Elsa has put and renewing it yearly or 6 in 6 months.
Or as needs change. Someone might have a UTI. If someone's got a UTI and has got delirium or confusion from an infection, then their capacity is then wavering. So can we take their word at those times accurately? I would also say, Mark, I think there's something in this quality statement around what this all means and blah, 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 about getting information to people in a timely manner. And it just triggered in my mind when we were talking about, when I was talking about UTIs, is if we've spoken to a doctor and the doctor said X, Y, and Z about this person, or they're moving on to this medicine, etc., how long is it then from having that phone call to going to that resident and going, this is what the doctor said, this is what it means, this is what you know, the medication you're going to be moving on to is this is what's going to happen, and have you documented it? Because they are going to want to see timely responses to people, timely sharing of that information and accurate information as well. So just be conscious about that, not just having all these conversations and then shoving it in a care plan and going, that's it, we've done it. Make sure that we've got all that information to them as soon as they've got it, whenever needed, Adam. Yes, totally, on capacity assessments and concepts.
I've also shared a link which the CQC link to. Ironically, they talk about all the accessible information around websites, but like we've said, don't do it on themselves. This NHS guidance is actually really in depth. When I managed a care home, this is what I used. It really breaks it down, what you should be looking for in your website, the font you should be using. Yeah, there's animated videos. It's got BSL interpretation on it. But yeah, go check that out. The only other things that I could think about around accessible information was around GDPR. So make sure that you've got a staff are trained, you've got a data protection officer, a DPO in place. Make sure that your policy around freedom of information requests is clear around response times, what platforms you use, what information is being shared. The last thing you want is somebody to be making a freedom of information request and then, you're not prepared and you're not ready for it. Right, on to the next one, which is listening and involving people. So we make it easy for people to share feedback and ideas or raise complaints about their care, treatment and support. We involve them in decisions about their care and tell them what's changed as a result. Adam, over to you.
Pardon?
Over to you, Sarah.
I'm teasing because it was all about listening. I wasn't listening. It was a dad joke, Mark. It was a dad joke. Again, this is where I think the quality statements fail, because a lot of them cover a lot of the same stuff. A lot of them are very sort of reflective of other ones. So people know how to give you feedback about their experiences. Well, totally. But we cover that in other areas as well. We cover that around access and information. Can they give feedback? Do they know how to give feedback? I suppose the access information is probably not specific to that. But again, I would just go back to making sure that your feedback policy is there and readily available. You've got it in easy read. You're using simplistic language. When I say simplistic language, monosyllabic. So where possible, don't use any more than 1 or 2 syllables. And if you are going to use words, don't use words that might need an explanation. Don't use anything that's vague. Don't use words that have got multiple meanings. Make sure it's really clear and really easy to understand. I used to have a poster that I would have up with different images on, so you can give feedback this way. It would be a speech bubble, and it would say email, and then there'd be a picture of an email, and it would be telephone, and there'd be a picture of a telephone, and it'd be in person, and it'd be a picture of 2 people talking. Because then you're giving multiple visual cues as well as really simple, easy language for them to copy, for them to understand. Make sure that they know that that feedback is anonymous. If they want it to be anonymous, give them the option to be anonymous. Make them understand, make sure they understand that they're at no risk for providing feedback. I know a lot of people have got that huge fear of, if I provide feedback, there's going to be repercussions to me. Make sure that that is clearly explicit, that that is not going to happen. Make sure, I've already said it's in various formats, but do that thing where you can make it audio. There are software systems out there where you can highlight a document and say convert to speech, and it will put it into speech. Shove a QR code on your poster so that people can QR scan it, and it'll take them to a link to listen to it. By the way, if you use Canva, you can do QR codes for free on Canva now. Canva Pro most probably, but I don't know whether you can get it on the free options. But all of that would really, really help. Make sure that you're going to take things seriously. Make sure that you're going to explain to them the outcomes of that complaint. Have you got a complaint investigation process that goes from beginning to end? So the process we have, for example, we receive a complaint, we respond within 3 days. We file an acknowledgement, so we've responded in writing. If it's over the phone, we'll still follow up in writing. We then evidence that we followed up in writing, then we'll do our investigation, we'll collect evidence, we'll decide whether the complaint should be upheld, whether it shouldn't be upheld. We do learning outcomes, so even if the complaint isn't upheld, we still do learning outcomes. We feed back to the people people who've made the complaint, and we give them, the sort of abridged version of what we found, plus our learning outcomes. We ask them whether they're satisfied. If they're not, what they're not satisfied about. We'll go back and we'll review, and then we'll go back until that complaint's closed, and follow through with that. Make sure that every sort of concern, worry, niggle is taken seriously, so that you are looking at it thoroughly. I think that's probably it for myself, Mark. And like I say, just evidence it. If you are going to do learning outcomes, evidence that you've communicated them to people and that you've built on them and you've worked on them and you've learned from them. So if you're going to do a learning outcome from an incident, from a complaint, from a concern, from a niggle, how have you then communicated that to your team? What have your team said about it? How many team members did you communicate it to? Did you communicate it a number of times because you only got a small portion of the team? And what sort of follow-ups have you done on that? So have you learned anything from that? Have you shown any improvements from that? Has anything similar happened after you've shared that learning outcome? Are you part of a larger group? Have you shared that learning outcome across the group so the whole group benefits? But all of that instills confidence in someone when they may not be fully happy with a service.
No, absolutely. The only thing from me, just on complaints, is in the acknowledgement and the outcome letter, I would just make sure that you're really transparent about that. They can go to the local ombudsman, but they can also go to the CQC. So there's no kind of nobody that can come back to you, whether that's an inspector, whether that's whoever's making the complaint, to say that you weren't open and honest. Just sharing a link around how the CQC website, they don't really advertise it, but you can signpost people here if they've made a compliment. You can also ask them to fill it in directly with the CQC, which I would definitely advise that you do.
All of this should be in your policy. All of this should be in your policy. This is who in this organization you can complain to, and you can complain to anyone basically. If you want to take it further, you take it to this person, you take it to this person, you take it to this person. You can also provide feedback to the local authority, both positive and negative. If you've got safeguarding concerns, you go here. If you've got concerns you want to raise to the CQC directly, you can go here. You can tell them about the good care, you can go here. All of that sort of stuff. Yes, Elsa, I mean, our complaints procedure actually has a notification section. So do we have to make any notifications? Is there a safeguarding we need to make? Is there a CQC notification we need to make? Is there a SUI involved here, an SUI? Do we have to enact duty of candour? All of that is super important. Duty of candour being a regulation at the end of the day as well. So don't get in breach.
No, absolutely. You definitely don't want to be in breach. I'm also just sharing some links in. I did a blog around how to handle complaints, which was then picked up for a second part that's got an infographic, just steps 1 to 7 that you can utilize with your team as well in a team meeting. So I'll share them in a minute. But first, I will come back to the next quality statement, which is equity in access. So we make sure that everyone can access the care, support, and treatment they need when they need it. Adam, back to you. And while you're talking, I'll just share this complaint stuff in.
Well, again, very, very straightforward. This comes back to that whole person-centered angle. It's like saying, well, everyone can have 3-course dinner at our home. Perfect. Everyone can access a 3-course dinner. Does everyone want a 3-course dinner? Do people want smaller meals throughout the day? Does someone want a larger meal in the evening and a smaller meal in the afternoon? Are your meals vegetarian friendly? Are they halal? Do you cater for nut allergies? Do you cater for lactose intolerance? And if you don't, what are those other people going to have? Well, they just have fruit as a pudding in those instances. Well, why are they only just getting fruit? Why aren't you doing stuff that is specifically catering to their needs? Yes, you're providing them with their basic nutrition, but you're not really doing anything that treats them with equality. You're just giving them other stuff, making sure that the rest of their treatment, that was just one very sort of rubbish example, but you're making sure that the rest of their treatment and the support that they get is in a way that that works for them. Are they going to have a vaccination? Yes, they are. Great. Where are they going to have that vaccination? Do they need to have something in the morning before they have that vaccination? Are they more at ease with the vaccination in the morning or an evening? If it's in an evening that they're more at ease to have the vaccination, make sure they have the vaccination in the evening. Don't just do a blanket treatment. Everyone's having the vaccinations at this time. There are ways and means around this. You should be able to work with people and say, look, that's not going to work for this individual. We've documented it this way. This is what we need to make sure happens for this person. Making sure that people can access stuff without any barriers. So if someone isn't technological minded, isn't very digitally minded, there is an element of your service that are just digital, that you are able to provide them with other access. It could be that the majority of us are on digital social care records, and the minute we went to digital social care records, we sort of collectively forgot in social care that person owns their care plan and should be able to have access to that care plan at any time. So are we providing them, if they've explicitly asked this, are we providing them with hard copies of the areas of their care plan they want on a monthly basis? Are we supporting them to understand how to access their care plan on a tablet, for example? If you use person-centered software, there is no issue in actually making sure people have access to their care plans through, say, Relative Gateway. There are a multitude of ways in which people can access their social care records, and that we're not actually limiting them to getting it. Is there a place in your building that people like to go and spend their time to, but actually there's only steps to get there? How are you making sure that everything's accessible within your service? If you want to change part of your service, are you making sure that it still continues to meet everyone's needs who are with you? And if it's changing to a different type, are you sure that your environment and location meets those people's needs that you're looking to sort of support? There's a lot here, Mark, which you can consider, but it's all around just making sure that no matter what you're saying you're doing as a service, everyone can access it in a way that is meaningful to them and matters to them, and that there is no physical, digital, invisible barriers stopping people from getting what they want, making reasonable adjustments, adjusting for communication barriers. We've spoken about all of this already tonight, and it's about making sure that we really follow this through and embed it within your service, whatever type of service that might be.
No, absolutely. And I was listening to you when you started around 3-course meals and whether people actually want them, and are they then left out if they don't want that dessert or whatnot. And actually, there was something around milk that I kept seeing over social media, and this was related to children's services, so not adults, but could easily happen around free milk that government pay for, but those that have a dairy intolerance don't have the same access to it. So actually, services, parents, whoever it is that are paying for it, then have to go and buy the substitute, or if they're vegan or whatever. And actually around what that pushback is. And there's a big campaign. I think it's going to government. I think it's got over 10,000 signatures of families that are saying, actually, it's not right, that it shouldn't be funded. So that is something that could easily fall directly when you're planning your menu. If you've got somebody with an allergy, just listening to you there. The only other thing I would say is around the accessible premises. So think about external. I'd also think about visitors as well. So actually make sure that you've got an accessible service, even if you haven't got anybody living there with accessibility needs. Make sure that you're planned for should you have a visitor. Could be a healthcare professional, whoever it is. The last thing you want is somebody to complain that can't get into your service. But otherwise, no further bits and pieces from me here.
Yeah, no, and I'm just thinking around equity in general as well, and just go slightly off piece. Talking about what you were saying then about free milk and everything like that. Do you offer birthdays off for your team? Is that sort of a benefit that you have? Everyone who works for us gets their birthday off. Brilliant. Woo, go and celebrate. Unless you don't celebrate your birthday. And you might not want to have that day off to celebrate your birthday. What other benefit do I get? If I don't celebrate my birthday because of my religion or my culture, what benefit do I get? And it's making sure that everyone has got equity within your service, absolutely everybody, because it is super, super important. People who don't have children, making sure that they don't miss out because your organization offers free childcare vouchers, but for people who are childless, there is no additional benefit. So it's making sure that everything or everyone has equal opportunities within your organization, not just treating everyone the same.
Absolutely. Last quality statement. We are going to go over the hour mark, but hopefully not by much, because we're
Got
on
two
to the
more.
last. Well, which two have we got? Oh, we've got equity in experiences and outcomes. Don't know why they haven't merged this into the same, but we actively seek out and listen to information about people who are most likely to experience inequality in experience or outcomes. We tailor the care, support, and treatment in response to this. So the only thing I would add that we haven't really spoken about is how that comes from the top within your leadership, your SLT, and that filters down around training from your staff. And again, about how you're giving control to the people that you support to make those decisions every day. Adam, anything under this one from experiences that wasn't in the access one?
So, I mean, for a lot of this, it's around understanding, and this is quite hard for a predominantly Caucasian-led country. If you look at our leadership values, our leadership positions around the country, we are very heavily Caucasian, and of that, very heterosexual and cisgendered. It's around understanding what discrimination exists at this moment in time and what people might struggle with or might struggle having access in. Is it the fact that women get less support than men? Is it people of a certain age only get a certain amount of support? Oh, well, they're 70, they're getting on a bit, so let's just give them some antibiotics and keep them at home. Is it the fact that people from other cultures get treated differently? Is it because people of different skin color get treated differently? Is it because you're part of the LGBT community that you're going to get treated differently? So it's around making sure that we're listening to people's past experiences and understanding what barriers they've faced in the past and supporting them to make sure that actually those barriers don't exist moving forwards. Understanding what their individual experiences of discrimination, of that sort of unfairness is. Has that happened within our own service? Have we unfairly treated someone within our own service that actually we need to look at? Do people in our home think, well, absolutely every single year we celebrate Christmas, there's a Christmas tree and I get a Christmas present every year? However, I'm Jewish. When was the last time we celebrated Hanukkah? That really means something to me. When was the last time we got the menorah out and we lit the candles and we had a good Jewish holiday? It's about making sure that we're listening to everyone in our home and making sure the experiences they have are meaningful to them, and it's not just what's meaningful to us, which tends to happen quite a lot of the time. I would just say make sure that you're up on your free to hear, your human rights principles, just to make sure that the whole team and yourself understand what your responsibilities are within that free to framework.
Thank you very much. The only other thing I would say is we've focused it very heavily on the people we support, because I think that's where the quality statement goes. But don't forget your staff team as well. And just listening to you there, Adam, talking about birthdays, Christmas, and bits and pieces, making sure you evidence why you're making those decisions. So I think from like my own organisation, we have an employee voice program. The corporate thought it would be nice to give everybody their birthday off, went to the employee voice program, and actually exactly like you just said, Adam, not everybody would celebrate their birthday. So they didn't want that, so they rejected the idea. But again, we can document, actually, this is what we were thinking, this is what we've done, this is the process we followed. Actually, we've not implemented this, but instead we've implemented this because that's what the employees wanted. And again, you can then utilize that in your marketing, whether that's in recruitment, whether that's, you said we did, all these ways to then utilize kind of what you're doing with your staff team and the people that you support to listen to their voices. The only thing I would just link in with this quality statement is it does link in with the local authority framework. Again, this one under theme 1, so working with people. So the theme covers assessing needs, planning and reviewing care, arrangement for direct payments and charging, supporting people to live healthier lives, prevention, well-being, information and advice, understanding and removing inequalities in care and support, and people's experiences and outcomes from care. So I'll share this one in the link so that you've got that as well. It's interesting that only a couple of the local authority inspection routine is linked in with the adult social care provider one, but as there we go. Planning for the future is the last quality statement. So we support people to plan for important life changes so they can have enough time to make informed decisions about their future, including at the end of their life. So we've touched on this already, Adam, but any tips and tricks from you for this one?
Don't wait too long to have these conversations. Too often we wait way too long to have these planning for the future conversations, and we automatically go to death. Death. You are going to die. What do you want us to do when you die? What do you want us to do when you're dying? But actually, what do you want to do if you're not mobile anymore? What would you want to do if you develop swallowing difficulties? What sort of foods are you thinking that you'll want to eat? Do you want to learn more about that now? All of that sort of stuff, planning for the future, is planning for a lot of what ifs. And by the way, one day you are going to die. So how can we support you to die in the best way possible? What's meaningful to you? What is it that is going to be beneficial to you? What do you want to happen afterwards? What's important to you afterwards? It's around having those kind, compassionate conversations and evidencing it where you can. It's making sure that people's decisions are recorded, and they may not necessarily be able to be upheld all the time, but you near as damn it deliver it in a way that is meaningful to them. And that will come through the person-centered care plans, again, linking back to one of the earlier quality statements under this key domain, and sharing those with people. Have you got preferred places of care in care plans? Have you got preferred places of death in care plans? Have you got documented conversations around resuscitation? Have you got documented care plans around advanced treatments? Have you got documented conversations around ceilings of care? So I don't want to go to hospital unless I break my leg, unless I break a bone. If I end up with an infection, if I have a stroke, if I have this, I am not going to hospital. I've got an advanced decision form here. It's signed. I've got my LPA. They're going to act in my best interest. We've had an MDT discussion. We've spoken with the doctors. That's what's going to happen. However, if I am going to be in unbearable pain due to a broken bone, I would like to go to hospital. Making sure that those ceilings of care are in place, and then making sure that we've got documented around when people are going to be contacted at those times as well. Who is it that they want us to contact? Do they want us to contact everybody? Do they just want us to contact one person? Around making sure all of that is documented. And if we are withdrawing treatment, making sure that we've done it in a way where we've conversed with the family, we've conversed with that person, we've had the GP, we've done the MDT, and we're doing it in a way that isn't going to put that person in significant pain, distress, discomfort. It's not going to affect the quality of their death. Making sure that when we're having that sort of future planning, which is, end of life care plans, it's advanced care planning at the end of the day. It's making sure that they're looking at things that are going to give them the greatest independence, and we're doing that as well. So the least restrictive practices. How are we going to be able to meet your needs if this happens? Because you're going to be able to want to do this. Does the person have a dog? If they do, and they lose the ability to walk, how are they going to walk that dog, and how are we going to make that still part of their life? And plan for that moving forwards. Does someone have an advancing disease? Do they have Parkinson's? Do they have dementia? Do they have Alzheimer's? Do they have cancer? Do they have a disease which is going to get progressively worse? And if they do, have we got a plan in place and documented conversations of what they want to do at each step and each stage of this disease, the worse that it gets? So all of that is really important for us to be able to document and evidence within these care plans.
No, absolutely. And I think just two words that the CQC talk about throughout, and you'll see somebody's just put it actually in the comments. Respect. This is about recommendations in the future if somebody isn't able to communicate or express their wishes or their choices. So like you said, Adam, making sure you get in there earlier so that actually you know what people want. Also has sometimes the supported individuals refuse to do it, but we can ask for support next to family or close friends. And again, having that in that care and support plan, who is important to that person? Who can we share information with? The other one that they talk a lot around is the DNR or the DNA CPR, so do not attempt pulmonary...
Cardiopulmonary resuscitation.
Well, that's the one. Thank you very much. And around
By the
advanced.
way, don't forget, we don't sign those forms ourselves. We do not put those orders in place. The GP surgeries and the hospitals put those orders in place. We can say we've had a conversation, and we can say we've spoken to the GP because this person wants to have a conversation. But the people who should be documenting those mental capacity assessments around the DNA CPRs and the respect forms is the person prescribing that form, not us. We can say we've started the conversations and we've provided them information about the DNA CPRs, but it's not down to us to do the mental capacity assessments around someone wanting a DNA CPR. So do not get caught up on that. Don't think, oh, I need to do an MCA around DNA CPRs. No, you're just providing them information and signposting them. Totally not up to you to make that decision for them. They have to make that decision themselves. And if they can't make that decision themselves, it's a medical decision. And the person making that medical decision should be documenting that. So do not get burnt by someone saying, well, you've not got a mental capacity assessment for this. We don't need to go and ask the surgery where it is, because they will have done that. It's not you making that decision.
And I think the only other thing that this talks about, but I think could become more common as the movement grows and kind of picks up speed, and I think it's already in Parliament, is around assisted dying. So actually, if you've got people that might want to go to Dignitas or go to another country around assisted dying, what are you doing? And I'd be very careful. I'd probably get some kind of legal support to make sure that you're covered and your insurance and bits and pieces. But I don't think it's going to be that long until we probably have that in the UK. So actually having a, thought about actually, if we were to support somebody tomorrow and that's what their wishes were, are you set up for that? Because it could easily happen. Any of us could say, actually, I want to go to wherever it is, Sweden, Switzerland, whichever country it is, Dignitas is, but actually I want to go there and end my life. Actually, are your staffs, are you going to be able to signpost your staff to that kind of mental health resilience, because actually they're going to need it? Are you going to be able to support the families around that choice, especially if they don't agree with it? What does your paperwork look around that? Risk assessments. But yeah, definitely food for thought. And I know we did a podcast on assisted dying, must be 2-3 years ago now. But has suddenly had a surge in people listening, probably off the back of it being debated in Parliament. A number of celebrities that are advocates for it, that are end of life, that has made it obviously a lot more publicly known. So definitely think about kind of what's in the pipeline that could impact our services, is all I would say.
Agreed.
That brings us to the end of tonight's show, Adam, and around the responsive domain.
I enjoyed it. I'm struggling to be enthused. If I'm completely honest, I'm struggling to be enthused about it all at the moment, because I am itching to see what this report is, and I'm wanting to see if the CQC are going to listen to what people have said. I just want to see some change now. They're asking us to see ourselves. They're asking us to make these changes ourselves within our own services, to always get better, to always improve. And it comes to that adage, doesn't it, about leadership, do as I say, not as I do. Well, actually, we want to do as you do, and we want to see you improve as well. So I am hopeful that the single assessment framework continues and remains. I'm continuing to embed this within my service. Again, I would just say, make sure you follow the regulations. Make sure when you're looking at your quality statements and your key domains that you're linking this back to the regulations. Make sure you know these regulations as much as you possibly can do. Make sure your team know about the regulations, because yes, you might be assessed under those quality statements, but it's the regulations that put you in breach. So make sure that you're not in breach with those regulations, and that you're not going to end up with any sort of warning notices. I almost forgot the term then. Make sure you're not going to end up with warning notices. Those are the things that you need to be concerned about, is the regulatory side of things. It's that regulation. So as you're going through these quality statements, link it back to the regulations, understand the regulations, and ask yourselves, am I meeting these regulations in these areas? When I do internal quality checks, I will always look at that regulation and go, have we met all of these areas of this regulation? No, we haven't. We could be found in breach here. We could end up with a warning notice here. So let's try and work and focus on this bit of this area now to continually improve. But just get to know these quality statements as much as possible.
No, absolutely. And the only other bit of advice I would say, I know I quite often talk about following the CQC website, is to put it in your favorites, whatever, the CQC jobs board. Only because I think sometimes that offers insight into kind of where they're going. So we obviously know that the chief exec, the CEO role, is advertised. There's a Deputy Director of Assurance and Risk, which doesn't surprise me given the failings that they've got that. But there's a lot of roles around health on there. So community healthcare, specialist advisors, human tissue, a Director of Human Tissue Authority, finance and resources, clinical advisors, critical care advisors. So it looks like they're going very health orientated at the moment, but it won't be long before that's social care orientated. So it will just give us kind of an insight into kind of what they might be looking at. Can imagine if you have nurses, actually skin tissue, human tissue is going to be a hot topic potentially in the future.
Do you not think this is where some of the problems come with the CQC though? Because inspectors now are expected to inspect anywhere. They don't just have their own sort of specified areas. Whereas for me, I personally just feel it would be easy to have inspectors that focus on social care, inspectors that focus on dentistries, inspectors that focus on GP practices, inspectors that focuses on hospitals, because they know that stuff in and out. You know, and I just want a clear pathway of who does what the structure looks like, and what it means for everyone. Whereas at the minute, I don't think we really truly know.
A conversation for another day. But anybody that's going to the care show, day one on the keynote, we'll be discussing around the CQC and improving compliance. So definitely pop along, because we'll have the report, we'll have the outcome, and yeah, definitely a good subject that we want you all involved in. Adam, any closing words from tonight?
No, not at all. Apart from thank you everyone for joining us. I'm gotten quite warm now. I don't think my heating's on, but it's definitely gone warm in my house. Anything from you, Mark, before we go?
No, anybody struggling with the cold, do move down south, because it's still very much like a sauna down here. No, the only thing I would say, what's that?
What have we got on next week?
Next week, I won't lie, I don't have the tab open. I have no clue. I'm pretty sure it might be the well-led domain, which I'm looking forward to, because actually when you look at that quality statement, it's very different than all the others. Yeah. I say quality statement and I meant domain, but the quality statement's under the domain. The only thing I would say before you close this out, Adam, is just do check out our website, only because there's loads of free resources, bits that you can do with your staff team. We are going through a relaunch of the website, so hopefully we'll be able to reveal that very soon. But yeah, no, thank you very much for everybody tuning in. If there is anything you get stuck on, please do just reach out to us. Contact details are on the website. But yeah, if not, have a good rest of your week. Have a good evening.
Thank you so much. This has been the Caring View online health and social care podcast, chat show, and free resources. The show tonight, I feel like Sesame Street. Tonight's show was sponsored by the letter P for Prosperwell, the letter C for CBAT Care Business Associate Trainings, the letter A for Attis Care Insurance Brokers, the letter L for Log My Care, and the letter F for Florence. Do find out more about all of our sponsors on our website, or head directly over to their websites. Watch this episode back, share it with people that you know. It is going to be available on YouTube until the internet gets shut down or we get booted off. Either way, that is what it is. And we will see you next week live at 7:30. So take care. Good night.